This editorially independent episode of New Retina Radio is supported by Alimera, a global pharmaceutical company whose mission is to be invaluable to patients, physicians, and partners concerned with retinal health and maintaining better vision longer. Alimera. We see more together.
Welcome to New Approaches to Chronic Postoperative Inflammation, a new Retina Radio miniseries. My name is John Kitchens, and I practice Retina at Retina Associates of Kentucky. On this miniseries, we'll examine management strategies for one of the most confounding and frustrating complications we encounter as retina specialists. I'm talking about postoperative inflammation. If you missed one of our first two episodes, catch them after you're done listening to this one. We've heard from Lisa Faya, Daniel Kernan, Vidya Dendaniak, and David Eichenbaum in the previous episodes. On this episode, we're going to review best practices for following up on chronic postoperative inflammation patients. I'm joined today by two colleagues, Brian Doe from Retina Group of Washington in Washington, D.C. Hey, Brian.
Hey, John. How are you?
Awesome. Great. Thank you for joining us. And Dr. Katherine Talcott from the Cleveland Clinic in Ohio. Hey, Kat.
Nice to be here. Thanks for having me.
All right, let's jump straight into our discussion. And Brian, I'll start with you. You know, the first two episodes, we kind of covered the basics, but we're going straight to the deep end here with things. Let's say you have a patient. I'm going to give you a theoretical patient, has had surgery, epiretinal membrane removal, and they've had postoperative edema that partially responds to topical steroids. And we're talking about difluprednate, not any, topical prednisolone. We're talking about hardcore stuff, but hasn't fully responds. What's going through your mind? How do you evaluate that patient? What do you do for that patient?
John, are we talking about somebody who's phakic or pseudophakic?
Great question. Let's assume that this patient is pseudophakic at this point.
Okay, so assuming that this is somebody with a lens in the bag, then I sort of think to myself that we have the full armamentarium available for use. I personally am a big proponent of Ozurdex, or the 0.7 milligram dexamethasone implant. I tend to have a low threshold for going straight to that if there's an incomplete response to topical treatment. I sort of interpolate the data from the POINT trial, which I think you guys are probably familiar with, which essentially showed that intravitreal steroid leads to greater visual acuity gains than periocular steroid, at least in the setting of uveitic macular edema. So when treating these types of cases, I pretty much try to stick to intravitreal if I can. And then, nowadays I'm often thinking down the road about long-term management and what we're going to have to do to keep the macular edema under control, because we all know that if we let the macula continue to swell and deturgesce and swell and deturgesce, that's not good for photoreceptors over time. So I'm thinking about longer acting implants and whether or not a single injection is going to be enough to keep the problem at bay long term.
We'll get into that in just a bit because that's a fascinating area. A question for you is in this scenario, postoperative edema, how do you justify or get something like a dexamethasone implant paid for?
I think if we get into the details of coding and diagnosis, things like you said get a little bit complicated. I personally will use the other chorioretinal inflammations diagnosis code, which is H30.891 for the right eye and 892 for the left. I think that the actual source of inflammation is probably more in the anterior segment, the iris and ciliary body. And I think those are tissues that are releasing inflammatory cytokines. And then those cytokines are then secondarily leading to increased vascular permeability within the macula. So I don't know that you have choroidal inflammation per se, but you've got swollen retina, and luckily I haven't had any issues going that route.
Yeah, I agree with you. I think that's where the switch really flipped for me, is realizing that this is an inflammatory condition and not just a generic, CME. CME is more of a finding than it is an actual cause. Kat, Brian alluded to the pseudophakic patient. What do you do in the phakic patient?
Yeah, I think it's a little bit more complicated in those patients because, we always think about like, risk of sort of the cataract worsening. I think the patient population we're talking about here, like patients who have already had retina surgery, I mean, hopefully we've done a good job of letting them know that part of the process of having retina surgery means that they're going to need cataract surgery. I'm actually, in general, for retina surgery, pretty quick to get my patients cataract surgery. I think it just gives them sort of the best chance of getting the most vision back. And then, if you end up in the scenario where you have sort of swelling that continues on, it just gives you a lot sort of more flexibility. So I wouldn't say necessarily that it sort of changes my management too much, but I'm just really quick to sort of tell them, like, I think you're going to need cataract surgery, and maybe sort of just accepting that this might be accelerated while we're sort of controlling the retina. But I really like the points that Brian mentioned. And, when I'm taking a look at these patients on exam, I'm just really looking for, is there any vitreous cell that's left over? Is there anterior cell? Like those are sorts of things I think as you're seeing these patients to carefully look for and sort of document. It can help you with sort of giving yourself as many tools in your toolbox available to be able to use.
Is there a role, Kat, for fluorescein angiography in these patients?
I think so. I mean, as you sort of alluded to, these are patients who really do have uveitis, and you want to make sure, like, at least I want to make sure that I'm not missing something else that's going on. I want to make sure that someone doesn't have like a vasculitis that like I missed, or was something that was sort of indolently going along. I want to make sure that, I'm not missing sort of an infectious process. I want to sort of just see that there's, signs of sort of inflammation just generally there. So I think it can be helpful to get sort of an FA in these patients because, thankfully they're not our typical like post-surgical patient, but, there are ones that are often the most difficult to sort of manage because we think we fix them by doing surgery, and unfortunately, little things keep popping up that we need to control in order to get them the best vision possible.
And Brian, what about a laboratory workup? Do these patients deserve a laboratory workup?
So for me, I think it's difficult to rationalize if there isn't clear evidence of actual anterior chamber or vitreous cell. Obviously, there are other uveitic processes that may not manifest in that way that you might pick up on through angiography. I'll just give one quick example. I had a patient that one of my partners was taking care of after vitrectomy for rhegmatogenous retinal detachment, and for about 6 months she had macular edema that was somewhat difficult to control. And I end up with quite a few of these patients because a lot of my partners will sort of think to themselves, well, maybe there's something else going on here. Let's have Brian take a look. And I've had a couple of patients in whom we did fluorescein and indocyanine green angiography and found birdshot lesions, where they're sort of clinically occult, but are very apparent on ICG. And so I tend to get combined fluorescein and ICG on most of these patients, at least on initial evaluation, just because I don't know what I'm going to find. And obviously in those cases, you want to get a lab workup, at the very least, check for syphilis and TB. And, if there's characteristic lesions, an A29, things like that. But for, more typical postoperative CME, I tend not to get lab testing, especially if the FA shows a, typical pattern of petalloid macular leakage and, some disc capillary leakage.
Well, that's amazing. Listen, we're going to head to break here for just a few minutes and definitely come back after break as we get back with Kat and Brian and talk about how we take things to the next level in those patients that have maybe undergone an intravitreal injection, have had a response, but have an early recurrence or persistence of their edema. So please come back after the break and hear what Brian and Kat have to say about that.
This editorially independent episode of New Retina Radio is supported by Alimera, a global pharmaceutical company whose mission is to be invaluable to patients, physicians, and partners concerned with retinal health and maintaining better vision longer. Alimera. We see more together.
Welcome back to New Approaches to Chronic Postoperative Inflammation, a new Retina Radio mini-series. I want to examine this hypothetical patient with our two experts, Drs. Brian Doe and Dr. Kat Talcott. Kat, we'll start off with you. We talked before the break about how we manage these tougher to treat patients that aren't responding to topical therapies. And when do you think about going to something more long-term after a dexamethasone implant? Like, what are you looking for? What are you thinking about?
Yeah, I think that's a really good question. And I think that these are some of our most difficult patients to manage, and we spend a lot of time with them because we just operated on them and sort of have been following with them. So if drops aren't working, Ozurdex is usually sort of my sort of next go-to. I'm trying to get a sense of sort of how much better they respond to that implant than they were to drop. So I'm looking at sort of what the OCT looks like, how much of a vision gain they're getting if they're improving on the OCT. So do I think that there is more vision potentially to be gained? And I'm also taking a good look at sort of what the response is in terms of the pressure. Do they need to be on drops to control the pressure? Are they sort of having a bit of a response? And I'm trying to sort of get a sense in my head, is this someone who's going to need one sort of short-term implant and sort of maybe get over this hump of inflammation? Or is this someone who's really sort of setting up for sort of needing sort of long-term therapy? And I think I try and plant the seed with the patient too, after doing sort of my first implant. Like, it's possible that this would continue on. I think compared to some of my uveitis colleagues, and so I'm really interested to hear sort of Brian's take on this, I will typically do sort of more than one Ozurdex implant sort of before switching over. I want to get a sense of, does the pressure go up at all? Like, is the OCT still continue to improve? And after they need like two, and I feel like they're still going to continue to need something, then I think about sort of more like long acting sort of devices. Like a YUTIQ, I think, is a really good thing to consider in this instance, where it can really sort of provide some sort of basal control of someone's disease. And so those are sort of the things that I'm sort of paying attention to. And I also think of, is this someone who just had a standard ERM? Is this someone who had sort of a lot of inflammation beforehand and a big RD? Sort of all those things in my head.
And so, Brian, when do you start to think, okay, listen, I might need something longer acting, and what do you think about using at that point?
So I'm going to echo a lot of the things that Kat's already said. I personally am a big user of YUTIQ, and I use a lot of YUTIQ because I think that these patients are often undertreated and perhaps treated sporadically. We spoke briefly about the negative effects of recurrent macular edema. And I've certainly had a number of patients walk through my door, sort of managed with topical therapy by the cataract surgeon for X number of months. And, some of those patients I'll actually inject Ozurdex on day one without even, trying, the more potent topical therapy. And I begin to have a conversation with patients about longer acting agents like YUTIQ when we're talking about doing that first Ozurdex, because I often have the expectation that the problem is going to persist. If patients have difficulty sort of buying into that idea, then we'll usually say something along the lines of, we'll inject the Ozurdex, we'll see how it goes. I expect that in the next 10 to 12 weeks, we're going to begin to see a recurrence. And if that happens, we can always inject another Ozurdex, but shortly thereafter, we should be considering something a little bit more durable. I will say that I've used a little bit of Xipere in these cases. I think the jury is sort of still out as far as whether or not it's as effective or whether or not it lasts as long as advertised or as long as we'd hope. So I can't comment on my results right now. I don't think that's particularly valuable, but like I said, I've injected a lot of YUTIQ, and overall, I would say patients have done pretty well.
Kat, you had a little bit of a reaction to Xipere. Do you have any experience with Xipere? What are your thoughts?
I haven't used it before. A number, I'm fortunate to be at Cole, where I'm surrounded by uveitis people. And I know that they've been really impressed with it. I haven't used it myself, but I think it's something to think about. And I really like some of the other things that sort of Brian sort of brought up. I think one of the other things I'm really watching for in these patients and trying to get them to see sort of over time is things that indicate that they might need more long-standing treatment, like fluid fluctuation on the scans. Sort of, I try and sort of get a sense from them of, how much, if they have anxiety, if it's going to look worse, it's going to look better, how many times they're coming in. So sort of trying to get, them to start thinking around that we can reach into our toolbox and maybe treat them better by going to more long-term therapy.
And Brian, what if we have that patient that still has some persistent fluid, even with a YUTIQ on board? Maybe they've partially responded, but they still have some swelling there. Is there anything else?
First off, if we're talking just corticosteroids, what I've started doing in a few of my patients is, in the setting of, let's say a mild recurrence of CME or persistent CME after a YUTIQ injection, I found that some patients will then respond to topical therapy, because they've got a YUTIQ in the eye, they've got something that's, sort of releasing a baseline level of steroid, and then supplementing with topical for some patients is actually sufficient. And many of them prefer that over going back to doing an Ozurdex every 2 or 3 months, although some people do end up needing that. I have some patients that have multiple YUTIQ in the eye, and having double the amount of basal steroid release, I think helps a number of patients, although I do have patients with 2 YUTIQs in the eye that still need either topical therapy or Ozurdexes on top of it. If you've got somebody who's maybe a little bit more steroid sensitive, I do think that there is a role for anti-VEGF in some of these cases. In my experience, anti-VEGF tends to last maybe 4 to 6 weeks in these eyes, but VEGF is part of the the inflammatory cytokine profile, and it's just one of many things that we see sort of upregulated in the aqueous and vitreous of these patients, and luckily some patients respond well to that, so I think it's something to consider.
Now, I've had one patient, speaking of using both YUTIQ and Ozurdex, that responded to Ozurdex. It didn't last very long, so I switched them over to YUTIQ. They failed to get completely dry on YUTIQ, and I gave them a booster Ozurdex, and they've been set. It's like, and I took some of that from some of the learning we had from Iluvien, actually, where we would see these diabetic patients that just needed a little bit of an extra oomph to get over the hump. And once you get them dry with that long-term fluocinolone acetonide implant, they're able to maintain that. One last interesting case, and this is something that I've struggled with on occasion. How do you deal with the patient who has chronic postoperative edema in an oil-filled eye? And Kat, we'll go to you first. What do you do for that patient?
Yeah, I think it's hard and it's challenging. And, you feel like you finally got control of, the patient's RD or whatever, and then there's this fluid that pops up. My first thought, is, can I do something to reverse the problem? Can I take out the oil in this patient? Can I get it out sort of sooner rather than later? But, in some of these people, maybe you tried to take out the oil before and they recurred and now it's back, and the patient's worried that they could have a redetachment. So it's a hard situation. I've definitely used Ozurdex with oil in the eye and had success there. And in some of these people, if you're going to leave oil in sort of long term, it's something to think about. Do I need sort of more sort of long term sort of treatment for there? But some of these are our most challenging patients. So I'm interested to hear what you guys, how you guys approach these patients.
I'll admit that I've not had a great deal of success with periocular or intravitreal steroid in these oil-filled eyes. But having taken enough oil out and then sort of seen the CME resolve just by doing that, that's often what I sort of advise my patients to expect upon oil removal. Obviously, that's not always the case, and I have a guy who had a buccal oil for PVR detachment, and had CME for a couple of months, and oil came out and CME recurred, and he's continued to need Ozurdex injections every couple of months, but at least with the oil out, he's responding well to steroid, which he didn't seem to be while the oil was in there. But yeah, I think in general, the best thing that you can do is try to get the oil out. These patients have reduced effective vitreous volume. Whatever cytokines would normally be released are much more concentrated in whatever sort of liquid phase is sitting between the oil and the retina. So I think, in increasing that effective volume, you reduce the effect of whatever's floating around in there.
That's interesting. I had never thought about it like that, Brian. Obviously in a aphakic patient with oil, I'm going to avoid giving something, but I've had good success, Kat, with that scenario, putting an Ozurdex in an oil-filled eye that's either pseudophakic or phakic. And it does seem like it has incredible durability in that scenario. Like it lasts a long time when you can't get the oil out. I agree with both of you that the primary impetus should be to get the oil out, see if there's a membrane to peel or whatnot. Listen, this has been incredibly insightful and entertaining. I want to thank Drs. Brian Doe and Kat Talcott for joining me on the new Retina Radio miniseries, New Approaches to Chronic Postoperative Inflammation. This miniseries is wrapped up for now, but stay subscribed to New Retina Radio to see what else we have in store for you. And remember, go back and listen to the first 2 episodes that we had. For now, my name is John Kitchens. Thanks for joining us.